I'm Erin Nielsen, and I'm the lead palliative care social worker at the University of Colorado Hospital. The spring of 2020, when Colorado was experiencing its initial COVID-19 surge, I had the opportunity to join my colleague, physician Alexa Gips, in implementing palliative care services into our emergency department. In the spring, when our world and our nation was all collaborating, trying to figure out how to combat this pandemic and how to integrate palliative care services earlier, we were paying attention to our colleagues who were initiating palliative care into their emergency departments across the country and thought, we have to give this a try. So with very little notice, we implemented ourselves in our emergency department for 3 weeks, Monday through Friday, 8 a.m. to 9 p.m. We announced our presence through an email blast sent out to the department, and the two of us attended nurse shift change huddles for the first week, introducing ourselves and our services. Our goal set out to work with patients who were dealing with COVID, but we were open to working with anyone who seemed appropriate. And we identified patients ourselves, mostly through chart review. We also were referred by any ED staff, and we frequently rounded informally to each ED pod multiple times a day. Due to limited personal protective equipment, we often conducted our intervention through the telephone and led with the need for the patients to identify a medical decision maker, as the state of Colorado does not have a default hierarchy. After 3 weeks, we encountered 95 patients, and a majority of them were identified by Dr. Gips or myself, around 80%. 95% of those encounters addressed the patient's need to identify a medical decision maker, have it be either an MDPOA or a healthcare proxy. 84% of those interactions addressed patients' medical decision-making capacity, their ability or lack thereof, and 51% addressed their preferences regarding life-sustaining treatment, specifically their code status. Although this was a limited a small sample size, and it was single site and not for a very long time, we still consider this a successful pilot. We had a lot of factors that helped contribute to that, but recognizing that people in the emergency department are captive audience to beginning advanced care planning conversations, we took advantage and we began talking about who their medical decision makers may be and successfully documented a lot of that. We also identified patients who were less inclined to pursue life-sustaining treatment preferences through conversations about their goals. The reasons that we think we were successful is we had a lot of support through the emergency medicine department as well as our palliative care department. We were physically there and for extended hours. We rounded frequently, normalizing our presence and offering casual consultation and education about palliative care. And we saw the referral numbers and the appropriateness of the referrals increase over a 3-week time period. We also know that people in the emergency room are there for various reasons. And so we adapted our intervention based off of time constraints as well as their needs, and had a note that was specifically tailored to capture our individualized and direct conversations with them. At the end of our 3-week pilot, we sent out a qualitative and quantitative survey to the emergency department staff, and we got 43 responses, which based off of all the people that work in the department over a 3-week time period was roughly a 28% response rate. Of those responses, 98% said that they felt that the palliative care being implemented helped improve the care that they were providing to their patients, and 100% of the staff stated that they thought palliative care was easily incorporated into their workflow. So although our intervention was tailored or started because of the COVID pandemic, we feel like we could argue that integrating palliative care into the emergency department could always be beneficial for all patients. Thank you so much for your time and interest.
Hi, I'm Christian Sinclair, and I'm a physician at the University of Kansas Health System in Kansas City, Kansas. And I'm very excited to talk to you today about our poster talking about our combination multi-specialty clinic involving palliative care, rehabilitation, and psychology. At the University of Kansas Cancer Center, we have really great supportive care services, but we do not necessarily work in a collaborative fashion. We see patients in our own clinics, and occasionally we'll talk to each other when there's really challenging situations. But we have enjoyed each other's professional company and really like working together when we do get those chances. And we thought, isn't there a way that we could overlap some of our evaluations so that we could better see patients? And so we had been talking about this since 2018 to try and figure out a way that rehabilitation, palliative care, and psychology could work together in the same clinic, seeing the same patients, and really capitalize on our different areas of expertise. But as many of you may be facing your own institutions, getting space for palliative care services or any supportive care for a patient can be really challenging, especially in an outpatient clinic. So we talked about it, we dreamed about it, we planned what it would look like, we made a couple of presentations of leadership. And then with the COVID era coming in, we're on pause for a little bit, but then we realized, hey, telehealth has really just been unlocked, and we've never really talked about doing our clinic in a telehealth space. So let's try that out. And so we made a proposition to the leadership to do a multi-specialty clinic using telehealth, where we would all evaluate the patient over the same hour. And they were very open to that. Unfortunately, all of us had very busy clinical time, and we didn't have an area to put the clinic in very easily. So we took our precious administrative time, and we found a time where we're all together, and we took every other Fridays to say, let's do the clinic then. We collaborated with the palliative care nurses and our palliative care intake coordinator, and made a pitch to a couple of different oncologists to say, help us find your patients who are early in their treatment, who have a need for rehabilitation, palliative care, or psychology, at least a need in 2 of those areas. And please refer them to us, and we're going to do this pilot to evaluate them from 3 different perspectives, 3 different specialists, all in the same hour, saving the patient time, getting them the care they need immediately, and the follow-up from this multi-specialty evaluation would be in the individual clinics of rehabilitation, palliative care, and psychology. So we leveraged our technology. We have our Epic health records platform, and Zoom is integrated into our visits already. And we use REDCap surveys to get information about general anxiety disorder 7, PHQ-9, the Edmonton Symptom Assessment Score, and PROMIS evaluation, so that we can better coordinate and utilize that precious hour in talking to the patient, and really leverage, does the psychologist and the rehab person need to talk more and the palliative care person need to talk less. So we've already had 5 patients into our clinic. It's not very much because we're still in a pilot learning phase, but already the overwhelming response has been very positive from patients, positive from leadership. The oncologists want to know when they can get more of their patients in. So we are working on a sustainability plan with the target for next spring. If you'd like to learn more on how to do a multi-specialty clinic using a telehealth platform, I'd love to talk to you. We're planning to do research when we get to our sustainability phase, and so we hope to have some more publications out as well. But the practical aspects of this, it's great to have a conversation with colleagues.